but for the most part, you don't believe it. Check the text on my phone. It's all there. So I went through Herman's phone. He wasn't lying. Michelle wanted to hire him to take photos, and
If he comes, no, he can't go back.
ಇದು ಇಂಟರ್ನೆಟ್ಟೇ ಬರಲ್ಲ
ಸೌಂಡ್ ಇಲ್ಲ ಈ ಫುಲ್
ಇಲ್ಲ ನಂಗೆ ಬರಲ್ಲ
ಬರುತ್ತೆ ನನಗೆ ಬರುತ್ತೆ
ಇಂಟರ್ನೆಟ್ ಇಲ್ಲ ಇಲ್ಲ ಅಂತ ಇದೆ
ಇದು ಡೈರೆಕ್ಟ್ ಕನೆಕ್ಷನ್
Hello, Dr. Deepthi. I have made you the host.
Hello, sir. Yes, sir. I'll take care, sir. Thank you so much,
Yes.
sir. Good evening, everyone. Since only 20 have joined, we'll wait for a while till 50 people join.
Haresh,
ఎక్కడ స్టార్ట్
Good evening, everyone. Since 51, 52 have joined already, we'll start the session for today. Welcome to today's session on early clinical exposure modules being presented by groups A, B, C, E, and F. The presenters for today are Dr. Priyanka Pandey from group A2. She'll present on cirrhosis of liver in hospital setting. Next will be Dr. Payal Kasat from A1. She'll be presenting carcinoma of cervix in a classroom setup. Next will be Dr. Shruti KM from B1. She'll be presenting on Bell's palsy classroom setup. Next would be Dr. Naga Jyoti from B2. She'll be presenting on thyroid swelling hospital setup. Dr. Sonali Khake from Group C, she'll be presenting for both C1 and C2 on CA stomach and appendicitis in hospital setup. Dr. Manasa will be presenting on knee joint injuries from E2 group in classroom setup. Next will be Dr. KV Sarla Devi. She is from group A1, E1. She'll be presenting on foot drop in OPD or classroom setup. Next would be Dr. B. Sendil Kumar from F1. He'll be presenting on tracheo-esophageal fistula classroom setup. And finally, Dr. Jaswinder Kaur from F2. He'll be presenting on atrial septal defects in hospital setup. We'll have all the presenters do their presentations and then discuss each module. Since I've not allotted any one particular group to review the other groups, any participant who wishes to review is free to do so. We shall now move on to the presentations. We'll start with Dr. Priyanka Pandey. Dr. Priyanka, you'd want me to share this screen, right?
Yes, ma'am. Good evening, ma'am.
Good evening, Dr. Priyanka.
लगा के देना
Dr. Priyanka, can you see?
Yes, ma'am. I can see, but I cannot see the document. I can see.
You
the
can't see
screen.
cirrhosis of liver? You cannot
Yes.
see? Okay.
No, ma'am. I cannot see the.
Okay, I'll do it again. Can you see now, Dr. Priyanka?
I can see. Yes, ma'am. Thank you so much, ma'am. Good evening, everybody. Senior resource person and my dear colleagues. Please do not mind my voice today. I'm not feeling little well. On group A1 and the mode and the ECE which was allotted to us was cirrhosis of liver in the hospital setting. So the competency which was designed was
Dr. Priyanka, please hold on.
Yes.
Okay, please present again.
Yes. Good evening, all the respected resource person and my dear colleagues. I am Dr. Priyanka Pandey from Group A2, and the topic for ECE module which was allotted to us was cirrhosis of liver in hospital setting. And the competency which was designed was demonstrate understanding of alteration in normal anatomy and physiology of liver, Number 2 was demonstrate understanding of principles behind the clinical manifestations of liver cirrhosis. The objectives which we deciphered were, at the end of the session, the phase 1 MBBS students should be able to, number 1, describe the size and location of the liver. Number 2, define hepatomegaly. Number 3, define portosystemic anastomosis. Enumerate the sites of portosystemic anastomosis. Explain the anatomical basis of clinical features of liver cirrhosis. And lastly, explain the basis of treatment of liver cirrhosis. And the teaching learning methods which were designed were small group discussion, subject or patient with clinical examination, or we could show them a video in the classroom. The resources which are needed are patient or a subject, the faculty members, and the LCD projector to project the videos. The feedback could be taken in a way whether the student has understood the normal anatomy of liver, and he could correlate the anatomical basis of clinical features of cirrhosis of liver, and location and clinical significance of portosystemic anastomosis. Assessment can be done by short answer questions, by a clinical vignette, or an OSPE in a response to. And that's all from our side. Thank you so much. And I really am thankful to Dr. Deepti Shastri ma'am for giving me this opportunity. Thank you so much.
Thank you, Dr. Priyanka. I know you're not well, and in spite of that, you chose to present today. Thank you, Dr. Priyanka. Next, it would be Dr. Payal. Dr. Payal, would you want me to share the screen?
Yes, ma'am.
Okay, please hold on. Can you see the screen, Dr.
Yes,
Payal?
ma'am. Yes, ma'am. Ma'am, am I audible?
You are audible.
Yeah. So good evening, everyone. The topic for the ECE module given was carcinoma of cervix, histology of carcinoma of cervix. So the objectives for this ECE module that we have formulated are, at the end of the ECE session, students should be able to first give identifying features, microscopic anatomy of normal cervix in a histology slide. Second, explain the clinical importance of microscopic anatomy of cervix. Third, mention the prevalence of CA cervix in Indian population. Fourth, list the signs and symptoms in carcinoma cervix. Fifth, describe dysplasia and sixth, give the role of pap smear in diagnosing cervical carcinoma. So these are the objectives that are framed for this competency. Then the teaching learning methods that are to be used, there has to be a collaboration with pathology and gynecology. So it can be an interactive lecture, then histology practical class with microscope and the slides, and PowerPoint presentation of the slides in that normal slide of cervix, along with, like, in the pathology there's inflammation and CA of cervix. So those slides, PowerPoint presentation of those slides can be shown to the students. So accordingly, the resources needed are the pathology and gynecology faculty, then histology slide, histopathology slide, microscope, computer, and LCD projector. So feedback that we are expecting from students are whether the clinical significance of normal histology of cervix is understood, whether the need for taking pap smear for early detection of carcinoma of cervix is emphasized and instilled in the young minds of students. So a written feedback for the session will be taken. Now, assessment for this ECE module is in the theory exam, in the MCQs, the lining epithelium of cervix can be asked. Then in the practical exam, what can be done is identify the slide and mention points for identification of cervix. And third way the assessment can be done is via an auspice, by formulating an auspice, a case study for CA cervix with various response stations. So in this way, this ECE module for CA cervix histology of that can be formulated. I thank Dr. Dipti Shastri ma'am because the way it has come out is all because of ma'am. So that's all. Thank you so much, ma'am.
Thank you, Dr. Payal. We now move on to Dr. Shruti. She'll be presenting on Bell's palsy. Dr. Shruti, will you share your own screen?
May I, ma'am? I do want to share my screen.
Yeah, please do.
Yeah, thank you, ma'am. Shall I go, ma'am? Start, ma'am?
Yes, please.
Yeah, thank you. So, representing group B1, for our facilitator, Dr. Gunapriya ma'am, I am Dr. Shruti, presenting regarding the ECE module for first year students on the topic Bell's palsy, and our setting is going to be the classroom setting. So regarding a competency pulled out from the curriculum itself, competency AN 28.7, which covers which is explain the anatomical basis of facial nerve palsy. So we could pull out the objectives from this competency as discuss the nuclei course of facial nerve, describe the branches of facial nerve in face, enumerate the muscles supplied by facial nerve in face, discuss the extracranial course of facial nerve and its injury, identify the facial nerve and branches in the face in a specimen, demonstrate signs and symptoms of Bell's palsy. So teaching learning methods, we could use a Humpty number of options. We have many options, as in we could go in for a large group interactive session and or split up into small groups and go forward in depth along with the specimen demonstration of the course and branches of the facial nerve. We could do a video demonstration of a case of Bell's palsy, and we could show the students the different signs or the testing of the of a case of Bell's palsy. Yes, we could even give them an STL session, probably do their own preparation regarding the muscles taking part in it or supplied by branches of which branches of the facial nerve. Role play could also increase the interest in the session. And yes, we could also given a student seminar. The resources that are needed for the session is we could a PowerPoint is obviously the mandate, and we could give provide the students with a specimen video clip. We can bring in a clinician from the general department medicine to elaborate on this scenario, charts, patients if available, that is if there is no complication and if you have a cooperative patient and if they're willing to come, well and good. We can give the students a handout in prior to the session, and probably we'll have to prepare a pre-test and a post-test questionnaire, some of the resources that could be used. So feedback, we can get feedback from both students and faculty, and in regard to students, we can get feedback regarding how they have understood the facial nerve in terms of correlating it with a clinical scenario. So our feedback would be better if we go around that and how this EC session has facilitated them to learn better. And in terms of assessment, again, we could go for a case-based essay, short notes, a short answer question, MCQs. OSPE will be a great choice too. Again, we can give them a small, quick spotted test, Viva or quizzing is always a option here. Ma'am, thank you so much for this opportunity. I'm done, ma'am. Thank you, ma'am.
Thank you, Dr. Shruti. That was a very good presentation.
Thank you, ma'am.
Next, we move on to Dr. Nagajyoti from B2. She'll be presenting on thyroid swelling. Dr. Nagajyoti, would
Yes,
you
ma'am.
like to share your own screen?
Yes, ma'am. I would like to share my screen.
Yeah, please go ahead.
Is my screen visible, ma'am?
Not yet.
Okay. Ma'am, I shared my screen, ma'am.
Are you using a laptop?
No, ma'am. Mobile. Through mobile, I'm doing.
You have to keep the file open and then go to Zoom and then share it. If you have,
Otherwise, I'll send in our group, ma'am, main group.
Okay, yeah, you can send in the group and then read it out, and everyone else can read out from the mobile, I guess. Okay.
Okay.
Dr. Nagajyoti, I guess you have shared. What is, can you please unmute yourself? You're muted.
Yes, ma'am.
Yeah.
Shall I start, ma'am?
Yes, please do.
Ma'am, nothing is sent.
You're sent in the group, right?
Yes, ma'am.
Okay,
Ma'am,
please
Deepti
go.
ma'am,
Yeah. Yes, ma'am.
can I share the screen, ma'am? Because I have hers in my WhatsApp.
Sure, ma'am.
Shall I do it now, ma'am?
Yes. If you give me 2 minutes, I'll share it too.
Yes, ma'am.
Ma'am, Gunapriya ma'am, can you please share, ma'am?
Yes, ma'am. I'll share now, ma'am.
Yeah, please do.
Is it visible, ma'am, now?
Yes, ma'am, it's visible.
Yes.
Dr. Nagajyoti can read out from this.
Yes, ma'am.
I'll keep moving.
Okay, ma'am. Thank you, ma'am. Good evening, everyone. Myself, Dr. Nagajyoti, belong to Group B2, and our group resource faculty is Dr. Gunapriya Raghunath. On behalf of Group B2, I am presenting the ECE module, Thyroid Swelling in Hospital Setting, in coordination with General Surgery Department, in the form of an appropriate demo on patient with thyroid swelling, followed by a lecture delivered by the General Surgeon. The time allotted is 3 hours, of which I would like to allot time for introduction and instruction 20 minutes, for exposure to clinical context and discussion 90 minutes, summary and conclusion 10 minutes, reflections and feedback 30 minutes, for assignment 30 minutes. The preclinical faculty gives brief introduction about the topic and divides the students into small groups to make visit to the hospital, that is general surgery ward, for better and early clinical experience. The preclinical faculty provide an observation guide to the students. Observation guide provides the role of the student once they visit the general surgery ward. So the observation guide includes student has to watch one while the doctor taking history of the patient, that is preliminary history regarding any difficulty in swallowing, any difficulty in breathing, hoarseness of voice. As the doctor is taking consent from the patient for examination, observe the facial expression of the patient, whether tensed, agitated, excited, or dull expression. Ask the patient for any loss or increase in weight. 5. Ask the patient to put forward his hands and look for tremor by placing paper on his hands. 6. Takes permission to feel his pulse. 7. Look for exophthalmos. 8. Ask the patient to sip of water and swallow and observe the findings. 9. Inform the patient that he is going to examine the neck from behind. 10. Ask the patient to protrude his tongue and observe the findings. Then coming to the competency is describe the anatomically relevant clinical features of thyroid swelling. The learning objectives are, at the end of ECE session, phase 1 MBBS students should be able to 1. Describe the location, coverings, presenting parts, relations, blood supply of thyroid gland correctly. 2. Explain why thyroid gland moves up and down with deglutition. 3. Instruct the patient to make him or herself comfortable. 4. Inform the patient that he will be examining the neck. 5. Appreciate the position of trachea in a thyroid swelling patient. 6. Appreciate the location and presenting parts of thyroid gland in a thyroid swelling patient. 7. Explain the anatomical basis of site of ligation of arteries during thyroid surgery. 8. Explain the anatomical basis of goiter. So the teaching learning method will be interactive lecture, small group discussion, demonstration on live patient. Resources needed are actual patient, hospital ward, anatomists, general surgeons, audiovisual aids, and demonstration room in general surgery ward. Coming to the reflections and feedback. Reflections means where we can ask questions related to the ECE topic. And coming to the feedback. So the feedback will be taken from the students to improve such ECE sessions further, where the questionnaire will be given to the students and the students have to mark yes or no. The questionnaire will be sent, will be in the form of, do you think ECE helped you to understand better about the anatomy of the thyroid gland? Do you think ECE should be combined with regular anatomy lectures? 3. ECE aided you to know more about the topic than lecture. 4. ECE made you to realize the importance of learning anatomy. 5. ECE made the topic of thyroid gland more interesting. 6. ECE aided you to correlate the anatomy of thyroid gland with clinical aspects of thyroid swelling. And the assessment can be done in the form of multiple choice questions by Viva Voice OC and by giving a short answer questions, clinical based. We can even plan OSPI, or even we can conduct a summative exam by giving clinical based long answer question. Thank you. Ma'am.
Thank you, Dr. Nagajyoti. It was an elaborate presentation and very well explained about the ECE module.
Thank you so much.
We now move on to Dr. Sonali Kake. Would you like to share your screen, Dr. Sonali?
Yes, ma'am, I'd like to share my screen.
Please do.
Yeah. Madam, is my screen visible?
Yes, it is.
Yeah. Thank you, ma'am. Good evening, respected resource person and all my dear colleagues. I'm Dr. Sonali Khake from MIMER Medical College, Pune. I belong to Group C. We are mentored by Dr. Girija Shivakumar Madam, and I will be presenting the clinical exposure of two cases. One is CA stomach and appendicitis. I'll start first with the carcinoma stomach. So the design of early clinical exposure module for the first MBBS student in hospital setting, the competency which will be covered will be the describe the morphology of stomach, the embryology of stomach, describe blood supply, lymphatic drainage of stomach, surface marking of stomach, clinical correlations of acid peptic disease and carcinoma stomach, stomach bed, lesser sac, the relations, and the microanatomy of stomach. The objectives of the study are: what is carcinoma stomach, what is the blood supply of stomach, discuss lymphatic drainage of stomach with clinical correlation to carcinoma stomach, draw diagrams of blood supply and lymphatic drainage of stomach, explain the nerve supply in correlation to embryology, explain the reason of Tross sign, which Tross notes with the embryological basis as testicular carcinoma 2 presents with which Tross notes, demonstrate, this is list different tests performed for the acid peptic diseases, barium meal test, describe and discuss different tests for carcinoma stomach and histology of stomach. The teaching learning methods that will be required will be case scenario or problem-based learning. The resources which would be needed will be patient if available, or else the case history of previously admitted patients and the resource faculties. The feedback we would like to take from the students would be regarding whether the students have understood the morphology of the stomach, the microanatomy, morphology, and the blood supply of the stomach, and the clinical significance if it is understood well. The assessment would be formative assessment in the form of short essays, very short answers, and also can be taken in the form of OSPE. The practicals can be taken in the form of OSPEs, and various questions related to stomach, its morphology, histology, and embryology could be asked. I would like to present the second topic, that is a classroom based setting. The early clinical module for appendix. The competency we would like to study would be the positions of the appendix, embryology of cecum and appendix for referred pain, McBurney's point, the surface marking, clinical correlations of different tests. The objectives would be to study regarding the appendix, the blood supply of the appendix, what are the reasons for appendicitis, explain the reason for the referred pain localized to the embryological and its embryological basis, the common anomalies of cecum and appendix, to demonstrate the surface projection of appendix, to list the different tests performed for diagnosis of appendix, and describe and discuss the different tests for appendicitis. The teaching learning method used will be the case scenario, problem-based learning, and if available, facilitator's guide. Resources needed would be the surgical textbook, illustration books, atlases, handouts, videos, articles, and if available, any hospital resource person. The feedback would be taken from the student regarding if the student has understood the morphology and the clinical significance of appendicitis, and the structured feedback forms from performance of the students and feedback forms about the module. And also the reflections of the students would be taken. The assessment would be in the form of formative assessment, in the form of short essay questions, very short answers. And the practicals can be taken in the form of auspice, which would require to demonstrate the surface projections of appendix and anatomical basis for the test performed to do diagnosis of the appendix. Thank you.
Thank you, Dr. Sonali. It was nice of you to have presented two of them, and they were elaborate as well. Thank you once again, Dr. Sonali.
Thank you so much, ma'am.
We next move on to Dr. Manasa, who is to present on knee joint injuries. Dr. Manasa.
Good evening, ma'am. I want to share my screen.
Yeah, please do.
Thank you. Good evening, all. On behalf of Group E2, I am presenting. I thank our resource faculty, Dr. Sheila ma'am, for her continuous support and guidance. Topic here is knee joint injuries. Duration is for 3 hours in OPD setting. So anatomy department in collaboration with the orthopedic department will be presenting. So visits should be arranged in small groups so as to offer a better clinical experience. The clinicians should be made aware of the objectives of the module. Learning experiences, introduction and instruction to the students 20 minutes, exposure to clinical context 45 minutes, discussion 45 minutes, summary and conclusion 10 minutes, reflections 30 minutes, assignment 30 minutes. According to MCI document, the competency we have AN 18.6 describe knee joint injuries with its applied anatomy, knowledge, know-how, and it is non-core competency. Objectives at the end of the ECE session, phase 1 MBBS students should be able to define knee joint injuries, describe why knee joint injuries are common, describe etiology of knee joint injuries, enlist common knee joint injuries, describe unhappy triad, compare and contrast the ligament and muscle injuries of knee joint, compare and contrast years of medial and lateral menisci, compare and contrast injuries of medial and lateral collateral ligaments, compare and contrast injuries of cruciate ligaments, and describe patellar dislocation, describe patellar fractures, describe patellofemoral syndrome, describe arthroscopy. So teaching learning methods used will be OPD based, mostly OPD based, patient oriented, case based teaching with aid of arthroscopic videos, simulation based teaching, flipped classroom. Resources needed are patient, OPD setting or hospital ward, orthopedician, radiologist, faculty to guide the students, and audiovisual aids, videos, x-rays, simulation lab, study material, feedback from students to evaluate improvements in the module. How helpful has the ECE module been in improving their knowledge about gross anatomy of knee joint and its applied aspects, and which components of the program help them? And did the ECE module make them learn basic science subjects more interesting? Are they motivated to read further on this topic as a result of participating in ECE? Any suggested changes in the program that will help them to learn still better? Reflections from the students can be taken. What happened, so what, and what next. Feedback from the faculty also can be taken. Assessment, formative assessment by OSPI, MCQ, short answer questions, and case-based long essay questions. We can divide the groups into 3 groups. One group can observe the history taking and communication by the doctor. The other group, different tests and examination undertaken by the doctor for both affected knee and the normal knee. One more group can observe and identify the anatomical structures in the X-ray of the knee joint. We can encourage the students to communicate with the patients for better communication skills. And we did not include any anatomy part because we have different competency of anatomy of knee joint, and osteoarthritis also we did not include because we have different competency in relation with the knee replacement also we did not include here. Thank you, ma'am.
Thank you, Dr. Manasa. Again, it was a very well developed ECE module. Next, we move on to Dr. KV Sarla Devi. Dr. Manasa, can you please stop sharing? Dr. Sarla, will you be sharing your screen?
Yes, ma'am.
Yeah, please share.
Ma'am, can you able to see my screen, ma'am?
Yes.
Good evening, all. Myself, Dr. KV Sarla Devi, belonging to E1 group. And I thank my facilitator, Dr. Sheila Shiva, ma'am. And the topic which was given is foot drop. Need to be discussed in the classroom setting. So the topic of basic science here is a common peroneal nerve. The goal is the student must be able to recognize the clinical manifestations of the injury of common peroneal nerve. The expected outcome as per the ECE module by MCI demonstrate understanding of alterations in the normal anatomy and functions of the nerve and its clinical expression. Then observe test for eliciting normal functions of this nerve. So the learning objectives what we framed is at the end of ECE session, the phase 1 MBBS student shall be able to define foot drop, identify the nerve involved, enumerate the muscles supplied by it in the anterior compartment of leg and their actions, list the causes of foot drop, observe the deformity in the foot drop, elicit normal functions of the common peroneal nerve, and demonstrate the gait in case of foot drop. So the teaching learning method, what we selected are videos, interactive lectures with the use of videos, case-based learning, flipped classroom, think, pair and share, buzz group, and role play. The learning experience, it is taking 3 hours. Introduction and instruction 20 minutes, exposure to clinical content and small group discussion for 60 minutes, and DOAP session for the SLO 567 for 30 minutes, summary and conclusion 10 minutes, reflections and assignment 30 minutes. So total of 3 hours. So the clinical context, what we did is a 30 years aged Miss Srinidhi, an IT team leader, presented to the OPD with the history of difficulty in walking since 1 week. There is no history of injury in the limb or back. She gives positive history of habitual crossing of legs. On examination, the ankle joint is extended on the right side. The actions of muscles of anterior compartment of leg diminished. There is diminished sensation at the first web space. The patient was advised for peripheral nerve study of right lower limb and review with reports. So this was performed as a clinical scenario as a role play. The facilitator guide was Explain what has happened to Miss Srinidhi. What are the alterations in the normal anatomy and functions that lead to this clinical picture? How is the occupation and her habit related to this clinical scenario? How will the suggested investigation help to explain the clinical context? The facilitator will take, after this, the facilitator will take to DOP session regarding the SLO 5, 6 and 7. So the resources we needed are lecture hall equipped with audiovisual aids, actual patients if we get, and simulated mannequins and good internet connection. After the session, the reflections were sought about what has happened to understand the experience, what the student learned, so what, that is applied aspect, and what is next, the skills which the student need to be developed. Followed by program evaluation through feedback. Feedback is obtained from the student as well as from the faculty. From the students, a questionnaire or a Google form regarding how helpful has the ECE module been in improving your knowledge about the food drop. Which component of the program helped you to learn? Did the ECE module make learning anatomy more interesting? Are you motivated to read further on this topic as a result of participating in ECE? And suggest changes in the program that will help you to learn still better. And the feedback from the faculty or the expected outcomes achieved, and give suggestions to improve the ECE module further. And assessment, this is taken both for formative as well as summative assessment. The short answers questions through problem or case-based questions can be asked in MCQ and as well as Viva, of course, through the OSPI stations. Thank you, madam.
Thank you, Dr. Sarla. Once again, a detailed module development by you. Next, we move on to Dr. B. Sendil Kumar, who will be presenting on tracheoesophageal fistula. Dr. Sendil, will you be sharing your own screen?
Yes, ma'am, I'm sharing my screen, ma'am.
Okay.
Are you able to see my document, ma'am?
Not yet. Here, yeah, now.
Is it visible, ma'am?
Yeah, now it is visible.
Okay, ma'am. Thank you, ma'am. Good evening to the resource faculty and my colleagues. I belong to group F1. My resource faculty is Dr. Debabani. And the topic is tracheoesophageal fistula. To start with the competency, the student must be able to correlate the relevance of development of foregut in diagnosis, patient care, and treatment of tracheoesophageal fistula. Objectives: at the end of ECE session, the first year student should be able to describe the development of pre-laryngeal part of foregut, define tracheoesophageal fistula, describe at least 2 types of tracheoesophageal fistula, enumerate the signs and symptoms of tracheoesophageal fistula, correlate the clinical manifestations of tracheoesophageal fistula with defect in development of foregut, enumerate the diagnostic test of tracheoesophageal fistula, enumerate the treatment modalities of tracheoesophageal fistula. To move on to the teaching learning methods. So the teaching learning methods used are interactive lectures using videos of patients, x-rays, case scenarios, charts, and small group teaching. The resources needed: AV aids, videos of patients and the surgical procedures, x-rays, and charts. Coming on to the feedback, whether the student has understood the tracheoesophageal fistula and its correlation with development of foregut, which will be a written feedback. The assessment includes MCQs, SAQs, and reflection. Thank you, ma'am.
Thank you, Dr. Sendil. It was a nice, crisp presentation. Next, we move on to the final presentation for the day. Dr. Jaswinder Kaur, she'll be presenting on atrial septal defects. Dr. Jaswinder, will you share your own screen?
Hello, good evening, ma'am. My screen is...
Yeah, we can see your screen.
Okay, ma'am. So I am representing group F2 and the ECE module for first year MBBS student in hospital setting. The topic given is atrial septal defect and the competency is describe developmental basis of atrial septal defects. Objectives are discuss development of interatrial septum correctly, define atrial septal defects correctly, discuss causes of atrial septal defects perfectly, discuss incidence of atrial septal defects accurately, describe various types of atrial septal defects correctly, discuss pro-patency test of foramen ovale accurately. The teaching learning methods used are small group teaching, case scenario, videos, and we can plan the session with the linker session. We can plan with the medicine department or with the pediatrics department. Then in first we will divide this session into three categories: introduction and instructions to students 30 minutes, exposure to clinical case and discussion 90 minutes, summary and conclusions 30 minutes. Resources required are OPD setting, clinical case, and audio visual aids. The feedback is prior knowledge about the ECE topic, importance of ECE session in clinical correlation about embryological basis of atrial septal defects, what is the students being asked to observe, what the student might learn from the observations. Then the assessment part, it will be a formative assessment. It may be in the form of assignment or the project work, written in the form of problem-based questions or MCQs or viva versa. Thank you, ma'am.
Thank you, Dr. Jaswinder. That was a short, cute, crisp presentation. Well, all the presentations are done. And before we move on to reviews, I wish to share something that's been disturbing me since I myself allotted the ECE topics to the participants. This incidentally is related to what Dr. Bhavna has noted in the chat section. She has mentioned that competencies addressed in today's ECE modules are different from the competencies in volume 1 of the UG curriculum document. So her query in fact was, are we designing additional competencies? Well, Dr. Punita addressed this issue to me a couple of weeks back about missing competencies for ECE topics that have been allotted by me to the participants. I found that the competencies which were missing from the volume 1 document, in fact, were for 2 ECE modules, both of which have been allotted to my own groups, A1 and A2 groups. Now, I still chose to go ahead with the ECE modules with the same topics and blame it on my idiosyncrasy And I truly apologize for going ahead with those particular competencies. And I noted Dr. Anjali wanted to know whether CA cervix, actually these two ECE modules are CA cervix and cirrhosis of liver. And for CA cervix, Dr. Anjali actually asked, is the epithelium of cervix a core or non-core competency? So before we go on to reviews, I just want to do a small presentation on these two topics, CA cervix and cirrhosis of liver, both of which have missing competencies in volume 1. I shouldn't have actually taken up the competencies, but I still went ahead with it. So I just want to give you a justification for that. So please hold on. I hope you can see the screen. Can you all see the page that I've shared?
Yes, ma'am. Yes,
Okay.
ma'am.
So I'll start with CA cervix. Actually, Payal was supposed to present because Dr. Priyanka is not keeping well. She presented first. So I just want to go ahead with CA cervix. There is no competency, in fact, related to applied gross anatomy or histology of cervix. Now, I did mention to Dr. Anjali on the chat section that cervix is a core competency, histology, and the competency number is AN 52.2. And any histology, if you take any organ in the body, histology, the general competency that is mentioned is describe and identify the microanatomical features of so and so. So they have given female reproductive system, ovary, uterus, uterine tube, cervix, placenta, and umbilical cord, S and SH level, and it's a core competency. Lecture and practical, there is no integration, either vertical or horizontal. But I still chose to take it because cancer of the cervix is the third most common cancer, with estimated about 1.04 lakh new cases around 2020 during this year itself. And this is from cancer statistics of ICMR. I just thought we can integrate it with pathology and OBG, but of course this competency doesn't exist. We can take it as a simple epithelium of the cervix and applied histology. Again, I would like to mention there is no applied histology in the entire volume 1 document, but we do spend 70 hours. Earlier, I can't remember CBME, but earlier it was 70 hours for histology practicals, and we make them see the slides. It is difficult for students to identify microscopic picture of any tissue, but we insist they see that, then they draw and they cannot draw well, and we spend a lot of time in correcting them. For what? If we have never introducing them to applied histology. Again, I apologize for my own idiosyncrasy. During the review, y'all please tell me whether we should drop it. Next, I'll go on to cirrhosis of liver. I meant it as histology. Actually, what happened at the beginning is I just didn't go through the curriculum document and check if any competency existed for ECE. That's my mistake. I just gave ECE topics for upper limb, lower limb, thorax, abdomen, head and neck, neuroanatomy, and came down to histology and embryology as is given in the document. But there is no integration, there is no space for early clinical exposure as far as histology is concerned. Embryology, of course, tracheoesophageal fistula, atrial septal defect, ventricular septal defect, and phallus tetralogy have all been given as competencies. But histology alone, competencies have not mentioned. It so happened that Dr. Priyanka converted cirrhosis of liver into a gross anatomy instead of taking it up as histology. Here, I would like to mention that there is no specific applied gross anatomy for cirrhosis of liver as such. There is a competency for gross anatomy, which is called as describe and demonstrate major viscera of abdomen. In that, it is location, relations, and applied aspects as well. So we could take cirrhosis of liver as that applied aspect, though it has not found a mention in the competencies. Dr. Priyanka took up portocaval anastomosis as one of the features. So if you go to that, then there is a competency for it, AN 47.10 and AN 47.11, which mention the competency as enumerate sites of portocaval anastomosis and explain the anatomical basis of hematemesis and caput medusae in portal hypertension. Again, not very specific to cirrhosis of liver, but I still took it up, I'm sorry, because around 10 lakh patients of liver cirrhosis are newly diagnosed every year in India. And liver disease is the 10th most common cause of death in India as per WHO. And liver disease may affect every 1 in 5 Indians. Now, in integration part, I've just mentioned that general surgery in volume 3 has given mention of liver disease. And liver has been integrated vertically with physiology and pathology and biochemistry and not with anatomy. General medicine has integrated it with pathology. So I guess we need not focus on cirrhosis of liver. I admit it was my fault that I gave cirrhosis of liver as an early clinical exposure topic. So again, I would want discussions from all of you regarding these two aspects. So I'm done with my sharing of my views. Now we'll go on to the reviews. Anyone would like to review? Dr. Priyanka Pandey is not well, so she may not be around. I can share the screen. Can you all see cirrhosis of liver on screen?
No, ma'am.
You can't. Okay, sorry.
गणेश करना स्टार्ट कराइए नए बच्चे गणेश वो उनका तो स्टार्टिंग का गणेश करना होगी।
Dr. Shweta, can you please mute yourself? Okay, can you see the screen now?
Yes, ma'am, it is visible.
Okay, anyone wants to do a review? Any specific, since nobody seems to want to review, any specific discussion you would like to have? Any particular topic you would like to share, to be shared and want to review?
Ma'am, this thing called sites of portocaval anastomosis,
yes,
is actually required for cirrhosis.
Again, cirrhosis of liver can lead to portal hypertension, and that's how she has taken it. That is why, like hepatomegaly has not been given as an applied aspect. I don't know whether you have to go for, again, it is for discussion. Applied aspects of all organs are mentioned as one of the competencies. But there is a particular competency where particular applied aspects have been mentioned, like Kerr's sign or liver biopsy, like the site of liver puncture. That is the only applied aspect which has been mentioned as a competency in that document. Of course, portocaval anastomosis has been mentioned separately. And the anatomical basis of portocaval anastomosis is one of the deficiencies.
Because as far as I remember, ma'am, portal hypertension, we are having it as a separate thing when we are going for liver.
For portal vein, you mean?
Yes, ma'am. Yes.
Yeah. I guess, but cirrhosis of liver also causes opening up of portocaval anastomosis, but it's fine. It is one of the clinical features of liver cirrhosis, right? Caput
Yes,
medusae and varices and hemorrhoids and so on. But it's okay. It's
Can I
open for
comment,
this-
ma'am?
Yeah, please do.
Yeah, so ma'am, as you were explaining before that, you had given this ECE topic thinking of histology, and they have taken it, converted into a gross anatomy. But in taking it up as a gross anatomy also, because it's hospital setting, so even the slide can be a part of the same setting, like part of the investigations where they can explain the histology and changes during pathology in the same sitting, ma'am. Even if patient and gross anatomy has taken, both can be combined in the cirrhosis of liver ECE. Like if we are taking pleural effusion as one of the pleura as a topic of ECE, even radiological anatomy can be included. So similarly, cirrhosis with gross anatomy, portal hypertension features, as well as the pathology part, the slide can be a part of the same ECE. Is that possible, ma'am?
Yes, absolutely, Dr. Bhavna. It can definitely be done. It's just that, like I mentioned earlier, there is no competency actually about applied histology. But as you said, normal histology can be shown, and then pathology, like integrated horizontal, vertically with pathology and with medicine for cirrhosis of liver. It can be done. Sheila, ma'am?
Deepti ma'am, I would like to suggest that should we be including the gross anatomy part of that topic for EC? I think usually we deal with the anatomy part earlier, and here we are more concentrating on the clinical aspect as well as the other aspects and they are doing the observation. So what I feel is that more of the communication skills and such objectives should be also kept into this. And in this particular ECE, I think we need not go into the details of even treatment of liver cirrhosis is what I feel.
Yes,
Few of
ma'am.
my
Yes,
views.
absolutely, ma'am. Basis of treatment of liver cirrhosis is not needed, and I guess size and location of liver is not needed. Hepatomegaly onwards, it can be done.
And actually, I feel that whatever that guidelines which module which we have to, the guide which we should be giving should be very specific, so that we should be dividing the students into groups, and that guide should be given very clearly. The instruction should be given what they should be observing during the session, and after that the group should be discussing that. That is how the module has been given in the, that is by NCI in conducting an EC. So we should be having a proper guide which we are giving to each group. Like some students will be observing how the doctor is communicating with the patient, and even the students can also have a chance of talking to them and seeing about how the socio-economic basis, how they are coming. All these can be included in an ECE, and I think that is also very important part of ECE. That is they are getting an exposure to it is actually early clinical exposure they are getting. So such type of objectives can also be formulated in a module is what I feel.
You are right, ma'am. Just 1 second. Again, it's I myself gave this template because it was shared in a CISP workshop. This template. That is the reason I had shared this template. But yes, ma'am, as you have mentioned, the ECE module of MCI gives in detail about the learning, not just the competency objectives, but learning experiences, how the time is divided in the 3 hours. Then as you said, the guide, observation guide, and also a reflection of the students, how they do, and whether formative assessment is done or summative assessment and so on. You're right, ma'am. Observation guides are very important. And I guess we need to add in all the modules which are being presented today, where the observation guide is missing and learning experiences have been missing and details of reflective writing have been missing. Again, it's my mistake that I had not given it in the format, in the template.
Nothing like mistake. I was just trying to
No,
express
you're
that
right, ma'am.
it is
But
very
no, no,
important in
right,
the
ma'am.
ECE module.
Of course, ma'am, 100%. It is there in the ECE module actually. And I think we need to add all those who are missed out. It is to all the presenters as well. Please add go through the ECE module by MCI, which has been published by MCI. And whatever is missing, what part is missing in this format, please add that, especially the observation guide, which is really important. Thank you, Sheila ma'am. Dr. Kannan or Dr. Sonali, one of you has raised your hand. Punita ma'am, you have unmuted.
No, I unmuted for them only. That Dr. Sonali here. Just carry on.
Yeah, Dr. Sonali.
Dipti ma'am, the presentation which you gave regarding the liver cirrhosis was very elaborate. Here, I just would like to add that last year during the ECE sessions, we had a patient admitted with ascites. So we had shown the patient. We took the students to the hospital and we showed them the patient with ascites, and then we traced back and we completed the ECE module of liver cirrhosis or liver in that relation. So I just want to mention that. So even if it is taken in the form of gross anatomy, histology can be added, of course, but we can take it on the clinical part, like hepatomegaly is there, splenomegaly is there, which comes with it, or for some stages of portal hypertensions, and the students would understand the complications which may lead, the cirrhosis may lead to. So I just wanted to add that. Thank you all for a lovely presentation.
Thank you, Dr. Sonali, for your input. Shall I stop sharing this and share CA cervix? We'll move on to the next one.
Dipti ma'am?
Ma'am.
Yes.
Oh, yeah, carry on, Dr. Saket.
Ma'am, I want to know that whether SLOs which have been formed earlier in the competencies which have been dealt earlier are allowed to repeat in the forming of ECE?
I
like,
think we can actually. That is reinforcement of basic sciences with the clinical correlation. This is my view. Others can
Madam,
share.
During the formation of SLOs in the previous session, we were asked not to reinforce, but it may be taken as a lesson plan. But in this EC, we can see that number 4 of the previous one, number 4 or 5, is the enumeration of the sites of photosystemic anastomosis, which has been dealt earlier also. So is it needed to reinforce over here, or it could be dealt under the lesson plan?
Dr. Saikat, like Dr. Sheila mentioned, instead of focusing on the anatomical aspects as such, if we focus on the attitude part of it, the doctor-patient relationship, socio-economic conditions, maybe those could be, but then of course MCA has not given those as the competencies for ECE. It is meant to correlate actually. So maybe anatomical basis of the clinical features of cirrhosis of liver would suffice. In that, of course, portocaval anastomosis, the sites would be known. What do you suggest, Dr. Saikat?
No, I was telling ma'am that if it is being dealt in a class beforehand, when we have dealt the portocaval anastomosis, different sides, the upper part, lower part, and the middle part. So already the SLOs has been formed. So should we repeat this over here, or we will take it granted the students has already we can apply the thing over here in the ECE? I'm asking about that.
Yeah, like you're saying, I think only application can be focused on in the ECE because the anatomy aspect would already have been dealt
done
in the class. Yes, right.
Ma'am, can I say something?
Yes, ma'am.
Ma'am, I have 2 or 3 points. Firstly, that EC is 30 hours are allotted. So we need to use those 30 hours. And if we are talking about reinforcement, we already have so many competencies. So this way, I think we might waste away some of the hours in case of for reinforcement. Number one. Number 2 point is that when we talk about observation guide, is the observation guide useful for classroom settings of EC? Because in my perception, it is for hospital setting. So these are the 2 important points. One, I agree with Dr. Sakib that if we are using ECE or overlapping SLOs, then because when you're talking about the clinical anatomy part, we are incorporating clinical anatomy in didactic lectures, in other teaching learning methods. So ECE should concentrate mainly on those clinical aspects which we want to go into more depth, or which we, as you have very well elaborated in your presentation, which carry more of impact, clinical impact. So any views about this?
Anybody else would like to share their views? Dr.
Ma'am,
Sonali? Yes, ma'am.
I had actually raised this doubt during our training program, whether so it is what answer I got from the sir, that is from the nodal center sir, was telling that we have to conduct it as per that MCI guidelines. So it is a 3-hour session which should be conducted continuously as a 3 hours, and that is why they have given that module with all the details how to conduct an EC. So actually we can select only 10 topics from anatomy, which we have to deal, and it is very clearly given also, like 18 can be in the 18 hours, this one 12 hours in the clinical setting. So all those details are there. So even in the beginning, even I felt that why can't we take more hours and do the clinical exposure like 1 hour or like that, like many sessions. But as since MCI has given us the guidelines, I think we will have to stick on to that. And we have to take 10 sessions with 3 hours, 30 hours. We have to conduct in the same way like what is told in the ECE module by MCI. So what Punita madam said, what I understood is that should we waste 3 hours on this one clinical that is condition or something like that. And like what Punita ma'am said, even I have got a doubt about this observation guide, that is if it is in a classroom setting. So what I understood is that if it is in a classroom setting, we can show videos or simulated patients or role play. And in that also, we can bring an environment which is there in the clinical setting into the classroom, and we can train the students accordingly. So we will have to have a clear-cut planning for that, how to conduct the ECE session in a classroom also. Might be we'll role play with a simulated patient, or all these elements should be incorporated into that. And we have to conduct the session in the classroom setting. That is what I understand. I don't know others' opinions, please.
Ma'am, very well explained, Sheila ma'am. Thank you.
May I, ma'am?
Yeah, please. Yes, ma'am. Swati ma'am.
Yes. Myself is Dr. Kanansha.
Sorry, Dr.
Actually,
Kannan.
yeah. My opinion regarding this EC is that 30 hours which are allotted to the anatomy, what I understand that 18 and 12, whatever we have divided, in that again we can, depending on the criticality, means core aspect of the anatomy as well as the feasibility. On both aspects, we have to decide, we have to select the few topics, and whatever the core topics we can conduct, we have to conduct it. Maybe there may be depend on the feasibility of the institute. We can arrange the different topics for the ECE. That is depend on the feasibility of the institute, whatever the cases we have, especially for the hospital setting. And regarding the observation guide is required, I think, for the hospital setting. Because when we are taking to the students where they are the novice to that environment, they are, when we are taking them, they might be observing something else, what we are expecting to observe them. So that's why the observation guide is required. So uniformly, all the learners are going to observe the same things. They have to observe these things in this patient or in this case. So if we have provided them, they can more focus on that. Otherwise, they might not be knowing that we have to see edema or we have to see something else into this patient.
Thank
Very
you.
well.
Thank
Yeah.
you, Dr. Kannan. In fact, as I think Dr. Bhavna has again pointed out, in classroom setting, there is facilitator's guide, like observation guide for hospital setting, and classroom setting, there is a facilitator's guide. So there should be a guide for students. Where they need some guidance and what they are going to observe, whether it is hospital setting or classroom setting. Punita ma'am, you were saying something.
Yes, ma'am. One very important point, I think it's good Dr. Kannan mentioned, it came out is, like we have been discussing the topics allotted to ECE very well. You have, like, I'm really thankful that you elaborated that point very well. It has cleared many doubts about how to select the topics for ECE. Thank you so much, Deepti ma'am, for that. And though this was not part of our session, but you did it very well. One thing which really struck me right now over here is when we are talking about EC, because now that the discussion is going on, we are talking about clinical anatomy and how to incorporate. As Dr. Kannan said, we should be more concentrated on how to expose the students to clinical settings, whether it is simulated or in the hospital environment. Because when you're talking about clinical anatomy part, which is again a cognitive part, it can be dealt with many of other sessions. While these sessions with clinical anatomy can be used for developing their exposure, that doctor-patient relation, which again in the chat box, Praveen sir, I think he might join us at 8:30 again if we continue. And he also elaborated that these sessions should be used for developing the doctor-patient relationship, like those ATCOM module part. So this is again a very interesting point, which I think has come up because of the discussion today. This is my take.
Yes, ma'am, you're right, ma'am. In the 3 hours, it is difficult for us to reinforce the anatomy part of it and then focus on clinical part as well. And I don't know about the other medical colleges. I think anatomy department will be in the college block and the hospital block will be elsewhere. So physical distance also they need to travel. So we need to take care of all that, right? For them to come back for debriefing to the department. I don't know if any of you had practical difficulty in how to conduct those 3 hours, giving them some time to move from one place to another as well. So I guess there isn't enough time to focus on anatomy all over again when we are doing ECE session. And as you rightly said, Punita ma'am, we have to focus on the clinical setup, attitude, doctor-patient relationship, and other aspects of the clinical setup, and also clinical features and how a doctor examines a patient. That itself becomes important.
Deepti ma'am,
Gunapriya,
can I?
Deepti,
Yeah.
Deepti ma'am, can I?
Speak?
Okay. There are 3 people. Dr. Gunapriya has raised her hand. Sheila ma'am and Swati ma'am also want to. Can we go one by one? Dr. Gunapriya, Sheila ma'am, and Swati ma'am?
Yes, yes, ma'am. Yes, ma'am. Sure.
Yes, ma'am. Dr. Gunapriya ma'am?
Ma'am, actually, good evening, ma'am. Good evening, all of you. In the initial, ma'am, we had a lot of hiccups actually in implementing ECE because 150 students, we take them to hospital side. First of all, the venue, taking them to the ward to see a patient or to have a small lecture session in lecture hall in the hospital side is difficult, all the 150. Then after that, following which we divide them into small groups also. The problem was we were able to coordinate everything very well, but the surgeons and the departments, clinical departments with which we coordinated, they found it difficult to repeat everything again and again. Because if you do en masse 150, the students are not going to benefit at all. There'll be one, if you take varicose veins, there'll be 1 or 2 odd patients, and all 150 will not get a chance to see the varicosity in the patient. So that was another difficulty for us, ma'am, in coordinating and making them, or in facilitating the and motivating the clinicians to talk 2 or 3 times, dividing the students into 50-50 students each. Later, in the months of February and March, we 3 departments, phase 1 department, sat together and discussed and prepared our ECE in such a way that the students are divided into 3 groups, and 50-50-50 will go to anat physio biochem on the same day for ECE. So one batch will undertake, one ECE, anatomy ECE, one batch physiology, one batch biochemistry, and the following Saturdays we used to interchange like that. It was only 3 times for the clinicians to repeat, but otherwise it was very difficult for us to manage that way, taking all 150 to hospital side. And now year after with the COVID scenario, I don't know how it's going to be really easy to implement it also, ma'am. This is my view. Thank you, ma'am.
Thank you for sharing your experience, ma'am. Dr. Saikar, you have raised your hand.
Good evening, ma'am. I have a doubt that in the NCI module, it has been given 30 hours for the ECE, right? So is it for 100 students or 50 students or 250 students? Because we people are different from different medical colleges and we have different strength of students. So how can a limited hours like 30 hours would be applicable for where the 50 students are there and 250 students are there?
The 30 hours are meant for each student. Each student should have ECE for 30 hours. So 250 students, each student for 30 hours. I do understand that is why they have said 18 hours classroom and 12 hours hospital setting. And classroom setting, the preclinical faculty themselves can deal with the classroom setting. And even clinical setting, they do not insist that the clinicians teach them. Like you can get trained by the clinician and then enact the same thing, in the hospital setup. But it would be beneficial to the student if they watch an actual scene occurring in the hospital setup where a doctor is actually treating a patient. So I do understand these are the limitations, the number of students, less faculty, probably in, many of the private institutions, less number of patients. And in government hospitals, I think Praveen sir will be able to share his own experience. There are too many patients and the clinicians do not have the time to teach first MBBS students.
Exactly,
So these are all limitations. I do understand.
Okay, ma'am, my doubt has been cleared that it has been given to every student.
Yes.
Okay, thank you.
Thank you. Should we carry on with the others? Do you actually want discussion on each of the modules, or can we have a general discussion? Because this is, general would be better, right?
That will be better.
Yeah, yes, ma'am.
Neeti ma'am, one of my concern, can I
Yes,
just...
ma'am. Yes, ma'am.
My concern is that aren't we deciding on the topic of ECE earlier, and we are planning out the lesson plan or this module, and we are planning a day, we are fixing a time for this session or the topic. And on that day, on that fine day might be in, I don't think that most of the hospitals, especially private sector, might not be having that patient on that day. Isn't that a big problem for conducting ECE in a hospital setting?
Absolutely, ma'am. In fact, we faced that problem when we had head and neck, I guess. Dr. K.C. Shanti, if you are there, you can share that experience. Actually, we had scheduled, earlier we had a talk with the surgeons on thyroid swelling and all that, but there was no patient on that particular day, because when you're teaching head and neck, you would want the students to see something related to head and neck and not abdomen. Otherwise, they would not relate it, because this is their first year.
That is a big major issue for ECE is what I feel. Because we are deciding on the topic earlier itself, we are planning lesson plan, everything has been, or the module has been made. And on that day when we take them, it is not necessary that the patient will be there in the hospital setting. So that is the biggest issue where we are, compelled to do the ECE sessions in the classroom setting.
Ma'am, still we send them to the hospital. We found out what case
We
was
send
there.
them for something like IV and IM injections we took last year as a topic. And that we could send them to the hospital because we know that at any cost, it with IM and IV, we have got different areas also where we could divide them into batches and take them and show them and they could observe and all those things. So that was one of the topics which we chose where we could, boldly send them and where we know that it happens on a daily basis. The other things, that is a biggest concern. And when we formulate even the schedule we form, we keep this hours fixed. Okay, this day we are going to have ECE of this topic. So that is a big issue which I face. I felt that we have to look into that problem. So how can we, can we alter or suddenly, or we will have to keep many options or something like that. I really don't know how to handle that. So that is why most of our sessions last year, because it was the first time we are doing it as an EC sessions, we were mainly concentrating into the classroom settings only with a simulated patient or like that. So this is a big concern which I have got.
Ma'am, actually what happened with us is the previous day we came to know, there was no thyroid swelling the next day. And there were patients with other disorders, and there was a case with multiple enlarged lymph nodes in the neck. And we did think that was a very important clinical aspect as well, lymph node enlargement in the neck. And we modified our ECE module to enlarge lymph nodes in the neck and gave them a briefing regarding lymph nodes in the neck, and then we send them to the clinical setup. This is our experience. There are other people also who have raised their hand. Praveen sir has raised his hand. Can you please share your experiences, sir?
I would like to say here is this is very genuine problem that Sheila has brought forward. My take on this would be how to circumvent this problem would be yes, principally and conceptually, we need to spread out ECE throughout the year. Okay, one per month, something like that. That is fine. But looking at the local feasibility, what we probably can do, modify a little bit, is concentrate initially maybe on classroom setting scenarios, and then we prepare more modules than the minimum prescribed for the ECE purpose, and then take a call in consultation with the clinical departments, which are the likely cases which are commonly going to be available at any given point of time, and try and look at those topics and achieve the competencies that are desired. Finally, if we look at those 5 purposes of conducting ECE sessions, if we are able to achieve those 5 purposes, I think no way would be wrong. We need not be probably exactly 100% dogmatic that this is the way it has to go. Yes, concepts we will have to use and try to be as close as possible to the way things are given in the ECE model document. But I think local feasibility here plays a lot of role. And especially now with the scenario existing right now, I think it will be highly impossible for the new batch of 2020-2021, whenever it arrives, to conduct ECE for them the way it is prescribed. It will be definitely modified, and more emphasis will.
Sir, please go on, sir.
Yeah, so I was saying that it will definitely modify, and more emphasis will definitely be laid on the classroom setting scenario, and we will have to evolve something where taking patient's consent and the clinical faculty consent, we may have to really record encounters, patient encounters between the clinicians and the patients, and use those recorded videos in classroom settings and mimic the clinical science correlation part of ECE for sure. Visit to hospital definitely will be very much curtailed in definitely the next year for sure. That is what I feel personally.
Thank you, sir, for sharing your view, and you are absolutely right, sir. Private institutions do have a problem of less patients. You have poverty in plenty. You have so many patients, but due to the COVID situation, as you have rightly said, sir, maybe we have to modify and go back to classroom teaching with standardized patients, as Dr. Swati has mentioned, or role play and videos and so on. Dr. Shanti, you have raised your hand.
Yes, ma'am. Initially asked no, ma'am, for that. Actually, as madam told our clinicians what they did, even there is no patient, they did like role play. They made one of the PG to sit like a thyroid patient, and the clinician demonstrated how to examine a thyroid patient, what would be the complaints like that. So even the patients are not there, they created an environment in the OPD that the patient should not, that students should not get missed out the scenario, ma'am. So that's how our clinicians managed, even though the patients are not there. They showed some videos, and we for that ECE we actually divided the students into 3 groups. One group will be going to ENT department for the observing patients with upper limb adenopathy. We had patients over there. The other set of people went to Optal OPD for seeing eye-related disorders, and one set went to surgical department to see thyroid case. But their thyroid surgeons managed with the standardized patients, and they used actually PGs as demonstrators, ma'am.
Thank you for sharing your experience, Dr. Shanti. Dr. Sendil Kumar, you have raised your hand.
Yes, ma'am. Can you hear me, ma'am?
Yes, Dr. Sendil.
Ma'am, as this problem is rising because of patient, if we go send the students to ECE when we don't have patient, what to do with it? So now all the institute and most of the department, they have the audio visual aids. So what they can do is they can record when they are getting a patient, and they can keep it and store and keep it in the system. So when we are sending the students for ECE, they can showcase that video to the students, and then they can ask them to play a role model and demonstrate how to examine the patient or how to note down the points like that. We can ask the students themselves to do that, ma'am. So that is one of the suggestion which can be easily done. So once we have this compilation, then we can use it for all the batches when they are coming to the clinical side, when we don't have that particular case patients in the OPD, ma'am.
That's a very nice idea, Dr. Sendil Kumar. I remember once when we had integrated teaching session on Parkinson's, and we had called a neurologist. He actually got videos of the patients he had collected for several years. And that made the students feel that they were actually watching a doctor and patient. And in fact, they could watch all the nuances of a doctor-patient relationship in addition to finding out the features of Parkinson's in the patient, tremors and mask-like face and so on. So, Dr. Sendil, that's a very good suggestion that you have given. Anjali, ma'am, you have raised your hand. Okay, Gunapriya, ma'am. Yeah, go on.
Ma'am, may I share my experience, ma'am?
No.
Ma'am, can I speak, ma'am?
Yes, ma'am. Yes, ma'am.
Ma'am, actually, last year when they joined in August, we divide our phase 1 into 4 quarters, ma'am. 3 months like that. So for every month, 1 ECE session we had planned. So at the beginning of the quarter, we coordinate with the concerned clinical side departments and discuss the topics with them. We have 1 ECE coordinator from our department. With my guidance, myself and the ECE coordinator from my department used to go to the clinical side department, meet the HOD there, and depending on the case available there, and whatever topics is being covered at that time. In the first quarter, if you say September, October, November, December, whatever topic is being done. If it's limbs, then accordingly we coordinate with the ortho department to see if there is any nerve injury or a joint, shoulder joint injuries or anything available to be included in ECE session. And we prepared the topics for September, October, November in the first week of September itself, ma'am. So we used to go to the clinical side departments and meet them, discuss with them, depending on the frequency of the cases available, like inguinal hernia, whatever is coming up at that month. So we used to discuss whether it's available. And in the case of inguinal hernia and varicose veins, I think varicose veins we did in November, I think, and inguinal hernia probably we did in February or January. The patients were not available, but patients were asked to come on the day of ECE. I think 2-3 days prior, they were intimated through phone. They were asked to come for a checkup. All this is done free only, and we gave some tip for the patient, like getting him breakfast and lunch and all that. And we utilize the patient for the ECE session. So in advance, we prepare the topics depending upon what the timetable is going to flow like for the following 3 months. So the topic is also correlating with your timetable flow. At the same time, you can think about whether the patient is available, or you need to inform and get the patient, or you need to show only videos. And we had 4 sessions pending during lockdown for April, May, June, July. That was about to finish our 10 sessions. We had finished already 6 during the non-lockdown or prior to lockdown duration. From April onwards, 2 were classroom settings, so that went off as online lectures, Google Meet lectures, that was fine. The other 2 were again, we had planned for hospital setting. We could not do, like thyroid swelling and all. Thyroid swelling and prenatal diagnosis of pregnancy. Both these were done in the form of videos, ma'am. The clinicians, they did a video and they gave a Google Meet lecture also, delivered a lecture. At the same time, they recorded a video and sent us also how the prenatal diagnosis ultrasound is being performed, how the anomalies are being diagnosed. A complete video recorded lecture was given in addition to a theory lecture. And similarly for thyroid swelling, a complete clinical examination of a thyroid patient also was done through a recorded video, ma'am. So this is how we completed by the month of June itself, all the 10 ECE sessions. Thank you, ma'am.
Thank you for sharing your experience, ma'am. You have actually given a very nice suggestion about the patients being identified, and the clinicians do know their contact address and numbers. So like for examination, they tend to call, hemiplegia or like thyroid swellings and so on. Even for ECE, they could be contacted and called on the day of ECE. That's another good suggestion, ma'am. Thank you, ma'am. Anjali, ma'am, you have raised your hand. Anjali, ma'am.
Yeah, ma'am. Can you open CS stomach module, ma'am?
CA stomach, 1 second, ma'am. I'll just find out who had presented the CA stomach. I think they had shared their own screen, ma'am.
Okay.
The last CA stomach was by Dr. Sonali. Dr. Sonali, are you there?
Actually, I wanted to ask that in the resource, can we have a specimen, because it was written that the patient we can call, but the CS stomach patient, that how it will be a resource, I did not understand. So if it is a specimen and if it is a histopath slide along with the stomach slide, that will give a better understanding, I felt.
That's true, ma'am. I think Dr. Sonali is not around. I'll just check here. I have the slide as well.
Hello.
Hello, yeah.
I'm Dr. Sharda. Can I answer to that?
Yes, ma'am.
Ma'am, if you go to the old government college, like Bangalore Medical College, from where I studied, if you go to the pathology department, you have a specimen of Linitis plastica.
Okay.
So if you want, you can get the specimens and you can show them. It looks just like normal stomach.
Okay.
So depends on what resources you have.
Yeah, showing a patient. Yeah, showing a patient. I did not understand. That's why I asked.
It's okay, ma'am. No problem.
Ma'am, I don't know whether this was shared or anything, other changes were made. I'm not sure, ma'am. These are the objectives. Case scenario is
that
what?
is totally some of them
different,
what we have.
Right.
It is, yeah, no, ma'am. It was actually a lesson plan. When we put out, we put it as set induction, and the surgical person, then the anatomy people, what to take, how much time to take. Everything was written down, and then when the template came, I mean, it was not, I mean, it didn't come in properly. We even put up if you have observed, we even put up the questions to put in that induction, to set the induction in the class. And we also, gave that this one also format for that structured the feedback and reflections. And then we had also put the questions for the summative as well as formative assessments. So this is very detailed done up. And then when
Okay,
the template from the CISP2 came, I didn't know in the CISP2 they have shown this template. So anyway, I didn't like the CISP2 template. Sorry for that negative, but I felt it was not good. The old one was better, ma'am. It gives you that flow of thought. It'll give you a visualization of how you will take your class.
That's true, ma'am. I think Dr. Anjali's.
This template didn't do that work for me.
That's
For me,
true,
at least,
ma'am.
it didn't work out.
That's true, ma'am. Dr. Anjali's question is that patient, no, ma'am. Anjali, ma'am, you're saying resource was given as a patient.
Yeah.
Suggesting it should have been histopathology slide rather than a patient, ma'am.
Yeah. And the specimen of stomach, CA stomach.
Specimen of CA stomach.
Can be done, ma'am. Can be done.
Yes, ma'am.
Can be done. I always
Pathology
want
specimen.
more resources. Yeah. I always go in for more resources. And before CBME also, I used to go to other departments and I was very friendly with the other department staff. So I used to go and get whatever I wanted. I used to go and I used to, if they wanted me to give a request letter, I used to give them and get them.
Thank you.
I never backed out. This is from my postgraduate days. I used to do this. So I have this habit.
Thank you, Anjali, ma'am. I guess the
Thank you,
patient,
ma'am.
it would help us in counseling also, communication
Yes, ma'am.
skills,
Yes,
breaking the news.
I tried that
to
also.
the-
Yes, I have tried that also. वो भी
Okay,
किया.
thank you, ma'am.
And
Okay, thank you, ma'am.
when you are friendly with the clinical staff, they're very obliging, ma'am. Some of them, they will get the patient. That time, I have tried that also.
Yes, ma'am. Thank you, ma'am.
Thank you, ma'am.
It's true, ma'am. If you have good rapport with the clinical departments, it's very easy to get our job done. It's very true, actually.
I learned like that only. In Bangalore Medical College at that point of time, we had very good teachers. Of late, I am very sad to say that the things have become very bad in Bangalore Medical College. There is a compromise on the quality of teaching. That's what I hear from my juniors. But when I was there, my God, it was too good. It was excellent. And I still remember those classes when I take my class. Usually when I used to do the chalkboard, we used to have Balkrishna sir. Balkrishna sir used to draw the diagrams and he never used to use a duster. Kabhi duster ne use karte the, and he was, when demonstrating the specimens also, he used to take care that we also, ours was a huge batch of 250 students and he used to go 10 or 15 times and he used to demonstrate the same thing all over to all the batches. And I was one person as a PG who saw him, who used to go with him to help him with the specimen, the positioning and all I used to do. That's when I realized how the Balkrishna sir used to really help. I was wonderstruck. He used to go on and on 15 times in the 2-hour dissection hall. Government college students. I've never seen anything like that.
Thank you, Sharda ma'am, for sharing your experience with your teacher.
Thank you, ma'am. Yes,
thank you, ma'am.
Thank you.
Any other discussions? It's 10 minutes to 9. We have had a general discussion on ECE modules. I think we can break for the day today. And I guess based on today's discussions on 31st, when ECE modules will be presented once again, all the ideas that have been discussed today can be put into use and make it better. Like Dr. Sharda mentioned, the template seems inadequate. So it's better to go through the ECE module given by MCI, not the SIS2 one, and make a detailed one with observation guide or facilitator's guide and so on. Dr. Sendil, you have raised your hand.
Yes, ma'am. Can you hear me, ma'am?
Yes, Dr. Sendil.
Just I want to put forward a query to the forum, ma'am, since all legends are there, so you all can help me out. So the thing is, we are framing the ECE module with certain specific cases. will it be sufficient enough for a student to know only these cases, ma'am? When he comes across other cases, what will be the scenario, ma'am, when he's going to the second phase of his MBBS? So that time when he's come across some other different cases, will this EC modules will help him in some way, ma'am? Or we have to go with the specific region wise, we have to take the cases and we have to discuss and train the students. So I just want this as an open discussion so that since my framework project is towards this, so I can plan it well in advance how to frame the module. That's why I just want to clarify, ma'am.
My opinion, I'll just give. What I basically feel is that ECE is one of the methods of vertical integration. We are doing other kinds of integration where clinical cases are being discussed with the students by nesting. Applied anatomy that we tell, we are still going to talk to them about it. So ECE, like Praveen sir has mentioned earlier, it helps the student to understand the hospital environment and how to correlate clinical conditions with anatomical basis. So it doesn't mean that they will be restricted to just these specific clinical conditions. This is my opinion, but the others can give their own opinions as well.
Yes, ma'am. Even I agree to that. With the 10 sessions of ECE, we are not planning to expose the first year students to all sorts of clinical cases.
Exactly.
That is just impossible. So this is just what is meant by just an exposure to the clinical settings. That is only by this 10 sessions, which they will be having another 10 in physiology as well as another 10 in biochemistry. So that doesn't mean that we are going to give them all the clinical experience the first year itself. So it is just an initial exposure which they are getting, and further exposure is there, they are going to get throughout the years from second year onwards. So this is not meant for covering all the clinical cases in the first year.
This is a sensitization for the first.
Yeah, there's just a sensitization, that's all.
At least they will get the idea to correlate the things. So in future also they will correlate the things.
Yes, ma'am. As you rightly said, it's only an exposure in phase 1, ma'am. Slowly they'll pick up, and simultaneously in phase 1 itself, they're doing ECE in physiology and biochemistry also.
Yes.
So 10 clinical conditions there also simultaneously they're learning. So this is enough for phase 1 exposure actually.
Exactly.
Dr. Sendil, does it answer your question?
Yes, ma'am. Yes, ma'am. Thank you,
Deepti
ma'am.
ma'am. Deepti ma'am.
Yes, ma'am. Yes, ma'am. Go on.
I just wanted to end it on a lighter note. As Dr. Dr. Senthil has.
Ma'am, we actually missed Swati ma'am. We are missing all your quips and anecdotes and your analogies. So you better entertain us now. Go on, ma'am.
No, ma'am. As Senthil sir was pointing out, like how would this exposure be going? So what I feel is, Senthil sir, you are now exposing your students with a virus called as ECE. You would be seeing that infection, the signs and symptoms in the second year. Somewhere in the final year, you will be treating the symptoms of your ECE, sir. Like I would be making it more better and will be uploading it in our WhatsApp group. So it is just an exposure. The effect of
Picture abhi baki hai.
Baki hai, exactly. The effect will be seen in the next clinical year, sir. That is what I feel. Thank you. Thank you.
Thank you, ma'am. Thank you, Punja ma'am. Got it.
Thank you, ma'am. Dr. Shilpa?
Yes, ma'am. Ma'am, do we have a guideline for preparation of observation and facilitators guide?
Actually, in this ECE module, you can go through it. There is means for particular case, it will not be given, but you will get a good idea when you go through all the modules they have given in this ECE document of MCI. Please go through it. We can have a discussion on 31st as well.
Yes, ma'am.
Dr. Shantini, would you like to share your views?
No, ma'am.
Okay. So shall we end for the day? Anybody else wants to share anything? Anjali ma'am, you have raised your hand. Okay, thank you everyone.
No, ma'am. That was the previous raised hand. Yeah.
Okay, ma'am. Okay, ma'am. Yes, ma'am. Thank you, everyone. It was a great session. Thank you. So many ideas from all of you, and so many of you are involved in the discussions. And we actually, you all shared your institution experience with us. I think we'll all learn from each other as we have done today. Thank you, everyone. Looking forward to another great session on 31st. Bye.
Thank you,
Good
ma'am.
night.
Thank you, ma'am. Thank you.